No, aortic valve sparing operation, not a new operation. In this country, again, Sir Magdi started doing it back in 1979. It never published, so it never spread. And William Osler practiced in Canada for a long time before he moved to the United States and then to Johns Hopkins. And I don't know if you noticed the first slide that Steve Westerby showed. I wrote the quote because I was unaware of this quote, but he said that the credit to any new thing, it doesn't go to the man who has the first thought. It goes to the man who told others. And you have to, if you believe in something, you're supposed to spread the gospel. If you're a aortic valve or mitral valve repair surgeon, anatomy, again, is the whole thing. And believe or not, in aortic valve, from here downwards, it all affects the aortic valve function. So an ascending aorta pathology may affect the aortic valve function, even if the aortic valve is normal, the cusps are normal. So you don't have to have pathology of the aortic valve to have aortic valve dysfunction. When I started practicing, I did not know that 35 years ago. And from time to time, I opened the aorta, and the aortic valve was normal. You know, you are doing bentos on those cases because of a ascending aortic aneurysm with a normal valve. I don't want to bore you with anatomy anymore. But you have to know anatomy. You can't do, no cardiac surgery, no operation should be allowed to be done to a person who doesn't know. In my medical school, do you know how my exams were? I don't know if you remember Alex Cipollini, knife on the back. I was fascinated by that case. We had cadavers with knife through the wrist, and I had to describe every structure that was damaged by the knife. This is anatomy. If you could pass that exam, you could be a surgeon. You have to know anatomy. But you have to know pathology as well. In degenerative disease, the ascending aorta and aortic root, connective tissue disorder is by and large the most prevalent among humans, because inflammatory remains a problem, but there's not much you can do about it. You don't know very much about biology of inflammation. Infections are disappearing. I operated one syphilitic aneurysm my whole career, and I have done thousands of ascending aorta and arch aneurysm in my career. One syphilitic, pulsatile through the sternum, and it was interesting. Dissection is very prevalent, and you heard earlier this morning. And then the congenital heart valve. Well, the congenital, of course, the most common one is bicuspid. Talk about degenerative diseases only, which covers 95 or more percent. The degenerative disease of the ascending aorta is by and large is in patients who have a minor genetic predisposition, and that's the current knowledge of science today. But if they smoke, if they're hypertensive, they have hyperlipidemia, those cells, the elastic fibers, die rapidly. I can tell how old you are if I put you in a treadmill or on an echo and look what happened to your aorta when cardiac output goes from 5 liters to 15 liters. You are only as old as your arteries, unless God forbid somebody shoots you, stab you, or have a car accident. Otherwise, you're going to die only as a function of the age of your arteries. I'm 70, I have 0 calcium score. My aorta is still moving about 25% during exercise. It's unlikely they'll be dead in 10, 15 years. But the airplane going back home tomorrow might crash. Of course I'll die. But by natural causes, no. Is it genetic? Or because I spend half an hour a day pumping my cardiac output 12 liters? This disease here is acquired. We all have some form of degeneration, but risk factors accelerate the degeneration. Contrary, if you have anybody under 50 who has an aneurysm, by and large, is genetically linked, either bicuspid aortic valve, unicuspid aortic valve, or a genetic syndrome. Like what? Well, like those you learn in medical school. Early-Danlos, Marfan syndrome is the most prevalent one. Not the most common, but we diagnose more readily. Louis-Dietz, aneurysm, and the list goes on. And every few years they discover a new one because they discover a gene linked to abnormality. Familial and the sporadic. Sporadic means the one that you and I can be affected. I'm too old already, but you guys. Mutation, and suddenly you develop an aortic root aneurysm. And they do genetic study, they saw one new mutation that your parents did not have. Mutation happen all the time. And these are the genes linked to mutation. Some are very old, like the Early-Danlos is known for 20 years. The Cutis-Laxa, only 2 years ago. And the familial one is very complex. There's a very broad spectrum of genetic mutation that causes familial aneurysm. So you're normal, by the time you're 30, something, radiation, smoking, God knows what, you change and you pass your offspring. And unfortunately, whether we like or not, we're going to become dinosaurs, we heart surgeons. They're going to say, oh, there's a Belgian surgeon called Giovanni Alcuri who used to do this to the mitral valve, or that to the aortic valve. Can you imagine? Now we take the gene, the transforming beta 2, we give them some losartan, and everything becomes normal. Well, it doesn't, not yet. It might someday. And I think ultimately that's where it's going to go. But the frustration thing about medical therapy is that every time they discover why a bunch of new people develop one type of aneurysm, they block the gene, but the offspring still gets it. For now, we have to do something about it. We are plumbers. We have to fix pipes now until they discover the molecules, modulation of the molecules. We operate in aortic root aneurysm because they develop aortic insufficiency or the aneurysm might rupture. If they rupture, you don't see them anyhow. They die suddenly. They don't come to you. They're all TOPS material. Or dissection, and the lucky ones make it to a hospital. The only thing we have to recommend surgery is size. It's a gross assessment of risk, but there is nothing else available to. For Marfan syndrome today, it's 50 millimeter. Only if you can repair the aortic valve. If you're going to do a bento, 55. Because the risks associated with a bento outweighs the benefit of doing the aneurysm repair earlier. So the guidelines were changed, if you read it carefully, by the Marfan Association, only for the aortic valve sparing. 40 to 50, only for the aortic valve sparing. 42 for Louis-Dietz syndrome, all comers. That's a new syndrome, known for 10 years only, and they dissect any time. They dissect at 40 millimeter. Familial aneurysm, 50, if you can save the valve. If not, 55. Because the risk of dissection, rupture is 0. Dissection, rarely. And the sporadic can wait even longer. The difference between the aneurysm, the young, and this old is in this slide here. The blue triangles. And several of us, Gibrin and I, almost at the same time, we discovered this. So I have been doing this operation longer than he has, but it took me 10, 15 years to learn what he learned much sooner. That once that triangle becomes obtuse, it's bad news. That damaged the aortic cusps because it changed the scallop of the crescent shape of the aortic annulus. Where? Everywhere in the aortic root? No. Where the connective tissue is. In other words, only around the non-coronary cusp. The other side of the left main and the medial side of the right coronary artery is muscle. That doesn't change very much. The aortic annulus, until this paper was published, which is 15-year-old already, it's funny how things happen in evolution of knowledge. It coincided when he and I discovered that the annulus was dilated in most patients we operate on. This is the plot of 4,000 human beings, 4,000 died. They are age 16 to age 50. And the valve was saved for homographs, and the annulus was measured geometrically. That's how it is in the United States. But America is a mixed bag of cultures and mixed bag of race, so it's applicable to the whole world. This is me. I'm 185 tall. I weigh 75 kilos. That's my aortic annulus, 22 millimeters. I didn't believe, so I did an echo myself, 21, in multiple views through the transthoracic. So he's a guy who's 6'2" tall. My annulus is 21. I'm horrified if I need an aortic valve replacement one day. Because remember, this is millimeter. If you guys put a 21 millimeter valve on me, it means a 17 St. Jude. A 17 St. Jude is 21 millimeter outside. The internal orifice is 14 millimeter only. I want to have the worst mismatch surgeon ever created on me. So I know if I need an aortic valve replacement one day, I have to go to a surgeon who knows how to put a bigger valve, because normally aortic annulus is very small. Well, if it's too small for the aortic valve replacement, why is not for valve sparing? That graph you should have in our operate rooms. You ask the perfusionist, what is body surface area? She has 1.8. What's normal annulus? Well, normal annulus for 1.8 is 21 plus 3 or minus. So if the annulus is up to 24 or down to 17, that's normal. If it's 28, you better do something about, because already the patient has mismatch between size the annulus and size the leaflet. Primary aortic root aneurysm are disease that occurs in the aortic root first. All of them are genetically linked, including bicuspid aortic valve. Bicuspid aortic valve likely is genetic. The penetration is variable, but that 0.5% of us that get bicuspid aortic valve, or 1%, must have a gene that our parents passed to us. Express itself in the second, at any age, but the peak expression when you're 30-year-old, second and third, fourth decades. The secondary aortic root aneurysm starts in the ascending aorta, and because of wall tension, it propagates downwards and upwards. The annulus never change because it's not a connective tissue disorder or the fibrous skeleton of the heart. This young girl, one of the smartest women I met, smart because she was born in Cameroon, and she managed to immigrate to England. And she saw a cardiologist, a female cardiologist, that out of coincidence, I had done a valve sparing on her, because she also had the Marfan syndrome. And that's why she sought this woman. And she told, the cardiologist told her, if I were you, I would apply now for immigration to Canada. And once you get there, you go to Toronto. 2 months after she landed, she was in my office. And she said, I was told you can fix my heart and my back too. I said, back I can't. But she walks straight today, 7 years later. She had 3 operations on her back. There's a guy called Fleming, our neurosurgical service. He straightened any back, unbelievable. And he does gradually, multiple operations. She's supposed to be this tall. She has an aortic valve sparing, and she has a normal aortic valve in back now. Smart woman. Her echo, however, is shown to you here. Beautiful aortic valve. Incompetent. She has moderate AI. But look at the size. She's only about 5 feet tall. Mind you, she was kyphoscoliotic, so that didn't help. 29 annulus. Her body surface area was 1.7. Grossly dilated. She should have what? A 19 annulus, 20 millimeter annulus, maybe 22, but never 29. So if you do an operation above the annulus and ignore this here, doomed to fail. It's like a mitral valve repair without annuloplasty. If the annulus is dilated, the valve is incompetent. If you fix the prolapse, you cure the mitral regurgitation. But you did not fix why the mitral valve became incompetent. That is connective tissue disorder where the annulus is dilated. Here's the same way. It took us until the year 2000, 2001 to learn this. These patients who have dilated aortic annulus have 3 choices. We had 3 choices. Hugh Bento, the diagram is wrong. This is Kuchiku's modification of a Hugh Bento original operation, where he wrapped the aneurysm. Kuchiku showed that should be buttons. But soon after, 2 or 3 years after, you could have remodeling, you could have reimplantation. This we learned from its inception to year 2000 was a bad choice because the tissue underneath continued to dilate and the valve became incompetent. Mr. Sir Mag Yaqub himself found this out. If you look at his publication back in 1988, he did not know that. And they all became incompetent if they had connective tissue disorder. However, remodeling is a very good operation. And physiologically speaking, better than reimplantation. Because you don't put the valve in a rigid structure. In the patients who have secondary aneurysm and normal aortic annulus, it's a great operation to leave the annulus intact. Like this patient here. Massive ACE in the aorta. He had an aortic root aneurysm. The cusps are barely touching each other. Severe aortic insufficiency. That's not the problem. But the cusps are normal. But look at that. This patient is 1.8 body surface area, and his annulus is 21 millimeter. Normal annulus. This patient is an ideal candidate for the remodeling. You can do reimplantation too, but it's going to be a very small graft. I do remodeling. I think it's faster, easier, not much thinking. You can let the fellow operate. All I have to do is calculate what size the graft you need. Tailor in 3 tongues of tissue, the operation is done. As long as it doesn't leak, the anastomosis, which leak often, but it's done. But it is a good operation and a durable operation. It will last the lifetime of the patient if you do properly, because the cusps are normal and you restore normal anatomy. Bicuspid aortic valve is an entity on its own. Very prevalent though. And the natural history of this disease is such that many of us, if you have a competent aortic valve and no associated connective tissue disorder, we can live to be 70, 80, and die from something else with a normally functioning bicuspid aortic valve. If you look at any autopsy material for 80s and 90s, 1% population is still have a bicuspid aortic valve. So not all bicuspid aortic valve goes to the operating room. If you take a look at the natural history, there are 2 large studies. The Toronto one is the longest one, is ours, goes to 25 years. 1 patient in 4 never saw a doctor. So lived to be 70, 80, 90, and then, well, if bicuspid aortic valve is good enough to take you to 70, 80, or 90, why not to save if they're pathological? Because if you make them function okay, it can take you through your lifetime. And that's the inspiration why this half of 1% population. The 2% is grossly overestimated. No study ever showed 2% of us having bicuspid aortic valve. The autopsy material is one in athletes in California. They did 25,000 echoes, was 0.6%. In professional athletes, the professional athlete they have to have an echo, is 0.5%. They're still an athlete. They still exercise, play professional soccer or professional tennis or whatever. If you look at the natural history published from Northstead County in Minnesota or in Toronto, Ontario, 1/4 of them present themselves in the first 2 decades of life. And those are that we can change their life with valve sparing or valve repair, because most of them present with aortic insufficiency. It starts as mild, then becomes moderate, and the cardiologist keeps saying, bicuspid aortic valve, bicuspid aortic valve. And they wait for the ventricle to be 70 millimeters before sending to you. Well, no more. If we think it's a bicuspid aortic valve and the valve can be fixed, can be repaired, you shouldn't wait for the event to become bad. You show the survival benefit. He already showed that there is a survival benefit, like in mitral valve repair, to operate early as opposed to wait until the ventricle is bad. And 1/4 of them escape us. They live their lifetime and become old men, old women, then the valve calcifies. This is a very common phenotype that ordinarily gives bentos, where the non-coronary sinus is massively dilated and sometimes protruding to a, this is not a Canadian, by the way. I was in India last year, and they gave this case to repair, which we repair all right, it was perfect. But I was so impressed by the size, the sinus, I asked if I could copy the CT scans. The kid did well. Craig Miller, through one of my fellows, spent a year with Craig Miller, Shafi Fazel, beautiful, the smartest Iranian I ever met in my life. Unfortunately, died prematurely. Joined me 5 years ago and practiced for 1 year only. Developed malignancy and died, the poor kid, but bright, smart kid. He's going to make a major difference in cardiac surgery. We lost Shafi. He collected all the surgical cases, some 600 cases by bicuspid aortic valve, and he took a look at all the CT scans painstakingly to see which part of the bicuspid valve in surgical patients affect the surgeon. 13% was the root alone, 14% the ascending aorta alone, 28 arch and ascending aorta, and the majority had a combination. Mostly, however, posterior aortic sinus. The anterior sinus was normal, indicating that you don't have to do benting everybody. The one that Gebrin and I see are like this here. They come to you not because there's a huge aneurysm. The aorta is only 45 millimeters, but severe AI, and the ventricle is dilated now. When the AI becomes severe or the ventricle dilates, they call the surgeon. Not my guys anymore, because they know we can repair. They ask immediately if an operation should be done. This kid is only 17. You cannot have a 17-year-old and a 34 millimeter. So the mistake we made before the year 2000 was he and I repaired the cusps only. We did a Cabral stitch, like plaquete, subcommissural triangles to increase coaptation, and fixed the prolapsing cusp. 5, 6 years later, recurrent AI. Because we forgot about this year. We didn't remove the stress on the leaflets, which is dilated annulus. And he showed, way before anybody else, that the only operation that is durable is tube reimplantation. Dissect the heart down to this level here and reimplant the aortic valve like this one here. the diaphragm graft go way below the aortic annulus and have a competent aortic valve. Actually, since I'm showing this video, the one on the left show a perfect result of aortic valve sparing. The one on the left, however, was remodeling. The one on the right is reimplantation. You want a leaf like that, coapting inside the diaphragm graft, not in the outflow tract. And that they have at least 4, 5, 6 millimeters touching each other. Because you are cutting this in a single view, and this is a three-dimensional structure. If you have in the center 5 or 6 millimeters, you must have 2 or 3 millimeters everywhere, including the commissural areas. So coaptation height is a key for any operation to do, reimplantation or remodeling. We think 8 millimeters inside the root and 4 coaptation is adequate. I can show no premature failure in any patient who had at least 3 or 4 millimeters. Let me give you a paper now I present in New York, and it summarizes 2 surgeon experience only. We developed the PI in Toronto in such a way that we don't let every surgeon do this operation. And at least as long as I'm there. Once I retired, I don't know who's going to take, but so far, Dr. Feindel and I only 2 do this operation there. From 1989, the first one, to 2012, we had done 333, fairly young, 46-year-old. Almost a bit more than a third had Marfan syndrome. 8% acute dissection. And 17 patients had a previous cardiac operation, including 3 of them had had the Ross procedure, which I'm not sure this operation is very good for Ross anymore. Before the operation, most of them had normal aortic valve. In other words, the primary indication for operation was the size of the root. But 43% had AI. And the 9% had acute dissection, they are so sick, we took to OR directly without an echo to assess aortic insufficiency. And this summarizes what was done in the operating room. Most of the patients had a straight tube of 30 millimeter, range from 26 to 34. Almost 40% require cusp plication. The cusp was prolapsing. You did a reimplantation, and the cusp was too low. So require plication, the free margin, to bring it to a good level. It's no different than mitral valve repair. You saw showing those triangular resection. We don't resect as many here. We plicate only, because the tissue is much finer than the mitral valve. Thinner. For a while, I was creating neo-aortic sinuses. I stopped in the past decade. Makes no difference. And do whatever else the patient needed at the time of the aortic root repair. Bypass surgery or replacing the arch. It's a good operation. If it's done correctly, it's a long bypass. I don't know how long was the bypass. I don't have it here. I think I'll have in some other slide. It's a long operation. It takes 2 hours to do on the heart-lung machine. But they do remarkably well, better than Benta for some reason. 5 hours only to be extubated. There are outliers. A day in the ICU, and in 6 days they're home. And complications of any major root operation. The bleeding in Toronto is a local idiosyncrasy. We don't let patients bleed. You put some tubes in. If in the first hour it's 200 cc's, they paid you. In the second hour, it's 200 cc's, operating room is booked. And often you open, you find nothing. You wash it, close again. So even minor coagulopathy forced to explore a patient. I look at every single up note of these 30 patients that only about 2 or 3 need a reexploration. because of coagulopathy. And coagulopathy is not uncommon in long pump run. But you had some serious problem. The very second patient in the series had moderate AI in the operate room. In the first post-op day, I couldn't leave moderate AI. It was a new operation. I didn't want to ruin my reputation as a surgeon, so I took him back to OR. I did a bent on him. But this is a learning curve. I didn't know how to do the operation yet, 25 years ago. One patient developed SAM postoperatively, severe SAM, couldn't be managed with beta blockers or calcium antagonist. About a week later, went back to OR to re-repair the mitral valve. And one of the stitches for the annuloplasty put a hole in the mitral valve and developed hemolysis. We had to go open the graft, put a little patch where the hole was, and stop the hemolysis. The patient who had a cardiac arrest, this patient here. Early in my experience, I used to put TCO. So I brought the graft down. TCO is a fibrin glue. I put TCO in the hole and then close. She thrombosed her entire aortic root, this woman. TCO in the aorta. In a minuscule amount, the whole big clot, and she arrested. And we opened, removed, washed the hell of the stuff. She lived, but she was sick for a while, the Marfan's patient. That patient required CPR. And then in the post-op, the hemoglobin kept dropping. The beta getting bigger. We had torn her liver. So back in the operating room, I reopened the whole thing and fixed the liver, and she was fine. The left lobe was torn during CPR. Price I don't think it's complication of surgery that we created, but you had to do CPR. She was dying, so only 5 patients require pacemakers in a hospital. And 22 developed defibrillation, 2 had TIAs, and unfortunately, very high proportion of platelets in fresh frozen plasma. Only 15% got blood, but they didn't require clotting factors. 4 patients died. Our mortality is, the way the government of Ontario collect data, is 90 days. It's not hospital deaths. They want you to see the patient 90 days and enter in the database. So we change our database to 90 days as operative mortality. 1 patient died in the first day from acute myocardial infarction. 1 developed IB dissection, malperfusion, and profound acidotic couldn't save him. We fenestrated, but still died. 1 older patient developed Clostridium difficile and died of infection. And a patient that stroked 6 weeks later at home after a maze procedure, a mitral valve repair, and he died as well. But 4 in 333 is just over 1%. A hospital death, only 2, but since we expressed at 90 days. When we first started doing this operation, I was seeing the patient myself every 3 months and doing a neck every 3 months. For the first 10, I didn't know if we were going to fall apart or not. Then as the confidence increased, we send them to a clinic and our cardiologist follow them. But Canadian healthcare system like yours is a single payer. Only the government pays. So unless the Canadian dies or leave Canada, we can track them down through the national healthcare system. That's why our follow-up is 100%. The only 6 patients we haven't had the echo for 5 years now are 6 Americans that came to Canada to have this operation. Went back home and they say it's too expensive to have an echo. The cardiologist told me, fine, what should I do an echo for? I try to tell them it's to help other people. They say, no, it's $400. It's too much money. I feel like paying to get their echoes. But everybody else had an echo every year. 35 late deaths, only 3 valve-related, all due to stroke. 5 cardiac, 4 due to dissection, and 23 other causes. We don't have very many patients at risk at 20 years, only 10 at 20 years. But that's quite significant here. And survival is identical to the population of Ontario, up to 15 years. No difference at all, including 29 with dissection, which is remarkable. Why they die? Well, they die because they are old, because they have coronary disease, because the creatinine was increased, renal function is impaired. And this is very interesting. It's the first paper I ever published where duration bypass had a negative effect on survival. The reliability is only 58%. But it is, nonetheless, by multivariable analysis. Longer the pump run, 20 years later, might affect survival. And this is multivariable. We tried to run because he had blood transfusion. No. And the size of the body. Big people don't live as long as small ones. But this is true for any operation. Those 400 pounds, we have a lot of them, 350 pounds. They don't live as long. It's a detailed account. Only 3 patients developed endocarditis. 1 aortic valve at 23 years of the operation. She was reoperated on and she's alive with a homograft now. And 2 mitral valve repairs, not repairs, mitral valve that became infected, 9 and 15 years. One was treated medically, she's fine. The other one had to repair the mitral valve, but he's fine as well. 8 strokes. The only predictor of stroke is age and type A dissection. People with flaps and aortic arch are more likely to dissect. In very, very few reoperations. 6 in aortic valve, 4 in the mitral, 1 total arch, and 2 thoracic abdominal in minor offense patient. And this is it. If you do a bento, you're not going to have 97% freedom from reoperation at 20 years. At least if someone has this data, they haven't published yet. Because when we reviewed this article, we did an internet search through Medline, through Cochrane. There is no bento that give a 97% freedom at 20 years. The only predictor of reoperation by univariate analysis, univariable, not multivariable, was the year of the operation. But it was a negative one. It was below 1, which is, am I getting sloppy? Am I getting old? Luckily, it didn't affect the multivariable. These are not people dead or alive. This is sequential. So this is not a Kaplan-Meier calculation. I'm giving the raw numbers. At any single time in the past 25 years, that's the sequence of the event. 212 patients never had AI, more than trace. 87 trace, 33 mild, and 1 moderate in the operating room. The last one now, in 229 operative survivals. So this is from the first day to the last echo in the last year. 3 severe, 8 moderate, 29 mild. It's going to fail. This valve won't last forever. And this is why I know that. The green means no AI or trace AI that can barely be seen at transthoracic echo. It started with an 84%. A week up, before they went home, they all have an echo in Toronto before they go. All valve surgeons have. Dropped to 81, dropped to 76, dropped to 63 at 15 years. You say, oh, but this is only trace. I know it's only trace or no. But look what happened to the mild. The mild is the blue. It was 11%, 16%, 19%, 20% at 15 years. The yellow is moderate. It's increasing. So likely the valve is degenerating inside the graft. We don't have enough cases, only 10 patients with echo beyond 20 years. If you do by Kaplan-Meier, it looks wonderful. But Kaplan-Meier's, 92% are free from any AI. But the previous slide is more realistic, more meaningful to us. Okay, here, if a patient died, it's eliminated from calculation. You know how Kaplan-Meier works. So these only people are surviving that time interval. Looks wonderful. My statement is arguable, though. You might say, yeah, but what you're saying makes no sense, because this is reality. If the guy is dead already, what do you care if it's AI or not? He died from cancer. Well, it's possible. And that's why Kaplan-Meier was invented. Because this gives more information to the clinician than what I gave you before. Couldn't find any multivariable analysis for AI. But by univariable, that's why I suspect that venture is going to fail. The most powerful predictor by univariable is time of the operation. Longer you follow them, more likely to have AI. In here, in this calculation, we lumped mild AI as well, only to see if we can find any clue why it's failing. Gore-Tex in the free margin was a powerful. I put Gore-Tex in some miserable hospital, I have to tell you. We used to repair anything in the early 2000s. Anything that looked like we put Gore-Tex in the free margin to resuspend, that was a mistake by univariable analysis. And size the aneurysm is a negative, plays no role. Implantation of the aortic valve into a tubular graft to treat the patient aortic root aneurysm is associated with very low valve-related complications, including AI. However, I'm not trying to be modest. I'm not trying to spread panic. I don't think it's an operation for life. If the patient lives long enough, they might come back for reoperation. But if they live long enough, 30, 40 years, that's the best possible operation. No people survive 40 years mechanical valve. Steve Westerby told you. He reported a case because I was alive 30 years later with a mechanical valve. That's a rarity. Most of us croak before. It's 1% per year a mechanical valve kills. So doing a 30-year-old, the chance to become 70 is very, very small. Thank you.